So thanks everyone for joining us for the 2021 Medical Careers Expo discussion with Victoria's Chief Health Officer about a career in public health. We would like to begin by acknowledging the Wurundjeri people of the Kulin Nation, traditional custodians of the land on which we meet today, and pay our respects to their elders past and present, and extend that respect to other Aboriginal and Torres Strait Islander peoples who may be here today. What we're going to do today is we're here with Professor Brett Sutton, Victoria's Chief Health Officer, and we're going to talk to him about his career in public health. And we're going to run through his personal experiences, some advice that he has for medical students and junior doctors interested in this career path, and also a bit about what he thinks the future of public health is. My name's Enes Kochak. I'm a vascular surgery trainee, and I'm here with
Carla. I'm a medical registrar.
Okay. And we'll probably just head straight into it.
Okay. So first section about your personal experiences, Brett. Can you remember when you decided that you wanted to pursue a career in public health?
It certainly wasn't a clear line in the sand. It happened by increments because I'd done clinical work and I was very happy with clinical work in emergency departments in Australia and around the world, really. But then I did humanitarian work with Doctors Without Borders, MSF, and increasingly was seeing public health at play, focused still clinically, but at a more population level and a health system strengthening level. And so it was at the end of some of that humanitarian and development work in East Timor that I got a real sense of the power of public health with vaccination programs and child nutrition, child survival programs, that in returning to Australia, I was pretty definitive then that I would look into what it would mean in Victoria without really knowing what it looked like. But I guess it was on my return to Victoria that I was really focused on exploring what it might look like and whether it would have some of the same challenges and benefits that I'd seen in doing public health in Timor-Leste and Ethiopia and Kenya and Afghanistan.
I confess that I had a sneaky peek at your CV and it looks awesome. What was it about public health that appealed? Like, do you remember at what stage after graduation it first occurred that you might want to do that kind of humanitarian work?
So my first trip to Afghanistan was 1997, so it was really early on, and I had some fantastic colleagues, Peter Salama, who's now deceased tragically, but a number of my year colleagues who did international travel, started to explore development and humanitarian work in various contexts in sub-Saharan Africa, across Central Asia and elsewhere, and they just had the most fantastic careers and most fantastic experiences. And so I kind of threw myself into it, looking up to Pete Salama as an EIS graduate from CDC in the US and as a Harvard graduate, and really loved it. It was absolutely clinically focused because we were working on setting up outpatients and hospitals and doing exploratory missions, and then treating individuals in a kind of mobile clinic setup, but increasingly with reflections on what the situation in those countries meant for population health and what some of those really fundamental interventions in water and sanitation, vaccination, health system strengthening would mean. And it just became clearer and clearer to me that you can make powerful changes in those settings. And in East Timor in particular, which was, a newly sovereign country, a fragile state by its own admission, were working to build those systems and make an impact on a very high infant, neonatal and child mortality in the country. And in the time that I was there, there was another demographic health survey. The child mortality had halved. That meant there were 3,000 children alive every year ad infinitum that wouldn't have otherwise been there, without that health system strengthening. And the project I was involved with played a really big part in that. So it's not to anyone's individual credit, but it really gave a sense of how much of a difference you can make. And I thought, could that apply in Australia? But the more I've reflected on it, what we've done in smoking cessation and, many other population level interventions, they are really powerful, and that became clearer and clearer to me over time.
Mm. I guess, a lot of us who go into the medical profession like to have an end goal. So, if you want to be a vascular surgeon, you sort of have that as your end goal, and you sort of can guess what the trajectory will be like. In public health, it seems like maybe it's not as clear. Like, was it for you, was it sort of taking it step by step, or did you already have an idea of what trajectory you wanted to take?
I think I had some trajectory. I think there are lots of benefits if you're really clear about that specific pathway you want to go on as a specialist or in a particular thematic field in medicine. But equally, public health, has that really significant breadth of competencies that you can focus on. For me, I always had a love of tropical medicine and communicable diseases, and I'd done my Master's of Public Health and Tropical Medicine in James Cook University, and then some of it remotely while I was working overseas and in Geneva for a bit. And so I knew that I really wanted to start in communicable disease, and that sits within health protection. So it's not the broader population prevention health side. It's really what I call the troubleshooting side of public health, where you respond to those challenges for notifiable diseases, outbreaks and clusters, and individual cases being notified. So that's where I jumped in. So it was as a team leader in the communicable disease prevention and control section before really having bigger management roles in that section and becoming the Deputy Chief Health Officer for communicable disease. So there are now 3 with COVID, but there were 2 Deputy Chief Health Officers, one responsible for the environmental health, food safety side of health protection, the other for communicable disease. And that remains my love in lots of ways, but I also think about the power of public health more broadly in the role of Chief Health Officer, and that's why ultimately I had my eyes on that prize.
All right, so I'll just finish this section and I'll hand over to you for the next section. Is that good?
Yeah, it's fine.
What have been your personal highs and lows of your career in public health?
Look, the highs are always in seeing great successes with certain interventions. The great dilemma and paradox, and I've spoken of it quite a bit in public health, is that the things that don't happen are your greatest achievements. They get no particular recognition. No one can say that they would have definitively happened otherwise, but you maintain health and well-being by virtue of stopping those events from occurring. And so having a really strong food safety system, having a really strong water safety with respect to clean water delivery, clean air, a clean environment, and there are always challenges in all of that, but they are the successes that it's very hard to hang your hat on them because we increasingly take them for granted as a population. But I think in particular what we collectively as Victoria have achieved through the second wave of COVID, knowing how it could have been and knowing how it's been for really the majority of the world's population, I could frame that as a failure, that we had a second wave, and in some respects it is a failure, but I also see it as a great triumph for Victoria because we literally could have had thousands of deaths, and there are jurisdictions across the world with smaller populations who've had 10, 20,000 deaths or more. And so I see that as a real high in many respects. Lows are probably in the same space, seeing a second wave in which 820 Victorians died, in which 20,000 people were infected with coronavirus, and knowing what that burden of illness will be for some time to come for many of them is a really terrible thing to have overseen and been responsible for. And that weighs heavily morally, but you have to own all of it, the good with the bad, and you have to reflect on what your motivation was through all of it. And there's no question that my team and the whole of the department working on COVID were all focused on maintaining the health and wellbeing of Victorians, and that's something for us collectively in health to be very proud of. But I think it's equally a triumph for the entire Victorian population. So I hope the pride is felt more broadly, because it was a massive collective effort that was by no means a certainty without that huge individual and population level effort, which is really the story of public health, that we're all in it together and that we each have to make those individual choices to support each other. And that's so true in infectious disease, where what you do as an individual isn't just about you as an individual, it's about all of those around you, and what that means for disease transmission.
Yeah. I mean, yeah, watching the trajectory at the time of the last wave and now seeing what other countries who are in a similar position where they're at is just, we're so lucky. So thank you for your work throughout all of that.
Thank you.
Can you talk us through how you got to be Chief Health Officer? Like, how did you go from sort of humanitarian, more sort of, I guess, less formal roles into that role?
So I'd really done 10 years in the emergency department, including becoming Deputy Director in Northwest Regional Hospital. So I'd done 10 years of clinical work, and then I'd interspersed some of that with going to Afghanistan. So in 1997 and 2003. And it was in 2003 that I was wanting to do more. And so I stayed on after that. I did come home for a time and did some locum work, but I returned to Horn of Africa and did 18 months there and 18 months in Timor-Leste, finished my Master of Public Health in Geneva. And I knew that I was going to work more definitively in that public health space. But I didn't know how and where, and I think a lot of people continue with a development humanitarian career. They can do it for 20 years or more. That said, I've seen some of them, and between the missionaries and mercenaries and madmen, it's a pretty tough gig as well. And I know that if you're starting a family, it's also not the place to be in Afghanistan, for example. And so getting married and then planning a family, I knew that I was going to transition back to Australia in all likelihood, but also that the things that I learned through humanitarian responses were going to be very useful in emergency management scenarios in Victoria. I didn't know what was going to be available. I didn't know how I'd feel about a bureaucracy and government and public service, but I just put my hand up and started in government. The roles of Chief Health Officer are public service roles. Across Australia, you're a medical practitioner. You don't have to be a public health physician. And Jeanette Young in Queensland, for example, is not a public health physician. She's a RACMA graduate and I think was an emergency physician. The statutory position is not the same across the country, but it was very appealing to me to look at Rosemary Lester and others who'd been in the role of Chief Health Officer and all of the work that they'd done. And I didn't make any assumptions about the ability to get there, but I was pretty keen in staying in government and doing that broad work in health protection, and to stay in communicable disease for a time. So becoming Deputy Chief Health Officer in CD, as we call it, might have been my career for 10 years if the opportunity hadn't come up to be acting Chief Health Officer when Charles Guest left the department. And then I was really explicitly thinking, is it appealing to do the broader public health work and thinking about the challenges of climate change, of antimicrobial resistance, of some of the other existential challenges with respect to clean water and clean air, again, taken for granted, but with bushfire seasons manifestly changing in the southeast of Australia, we're going to have really significant public health challenges going forward, and it became more and more appealing to be in the space to meet some of those.
Well,
Thanks, Brett. We might change tack a little bit and we'll talk about some of the advice that you might have for medical students and junior doctors. And I should say these questions have been based around some of the questions that you guys have submitted. So we're trying to bring all of that in because I don't think that we'll have time at the end of this for questions, but we'll see. We might start with what do you think are the common misconceptions that people have about a career in public health?
I think people often don't really know what the elements of public health are. Obviously, I'm trying to frame the bits that often sit under a chief health officer, that troubleshooting side of public health, but there are all of those other broad aspects of population and prevention health that I don't think are well understood, and I'm not sure people understand the profound power in some of those interventions. Half of the life years gained in recent decades in Australia have been through public health interventions. So they're the things that relate to how we regulate food safety, air and water, but also alcohol, gambling, the interventions for overweight and obesity, the interventions for chronic disease management are also part of a public health approach. And so I think it's more that people don't understand really the power and the breadth of public health interventions. I did reflect on the fact that the reductions in smoking prevalence in Australia have saved thousands upon thousands of lives. And as an ED director, I loved saving a life, with adrenaline through managing trauma and all of those other really critical conditions. But in a 20-year career, I would never have the opportunity to save thousands of lives in the way that you can in public health. And I think that's probably the most powerful reflection I had coming to public health. And I don't think, certainly I wasn't given enough of an opportunity to understand that was the case as a medical student. I think it was framed in a light, not particularly powerful way. And I think it was kind of community health, the coordination of services, or standardization of clinical care, and not those fundamental interventions of the social determinants of health that relate to equity, socioeconomic opportunity, early life experiences, the traumas of childhood, and interpersonal violence, and all of those things fall under the banner of public health. And I think there is no end of opportunity and interest amongst those elements if you're looking for it.
Thanks. We've touched on this a little bit already, but what do you think? Perhaps you could run us through some of the pathways that you think people should take or pursue to get into public health. I assume that you sort of alluded to the fact that there's probably more than one.
Yeah, there are many, many pathways, and there are lots of people who start a clinical career, maybe do a Masters of Public Health because they're interested in public health, get a fuller understanding of it, and then start to think about, well, what does it mean to be public health qualified, and what opportunities could it have for me? So, we certainly see public health physicians who've been general practitioners or emergency physicians, or who've done some clinical work for a period of time. But equally, you could effectively go straight from your hospital residency registrar years, do a Masters of Public Health. That's effectively your first part for being a fellow of the Australasian Faculty of Public Health Medicine, and then it's essentially 3 years of building the competencies across various domains that sit within public health, and doing your exams at the end of that 3-year period. So in many ways, it's more straightforward. You've got to do that MPH as your first part, but then it's on-the-job work. And so if you can find work across those domains, and you're really trying to go broad with that, it's great if you can do some time in health protection type work of outbreak management, environmental health, but equally you need to get across those broader population and prevention health elements, and then some of the epidemiological data analysis to inform policy and what it means to have competencies in policy development as well. So there's some really key competencies. A lot of people do remote clinical work, in particular with Aboriginal communities. They reflect on the fact that public health is probably the most significant interventions that can be made to improve health and wellbeing in some of those settings, and then come back to formal training. But having an understanding, for example, of Aboriginal health issues is a really significant competency. And so it's one that you can tick off in that setting, and then come back to some other settings often in government, but people also experience it through medical research institutes. They might have time at the Burnett or the Doherty Institute or Murdoch Children's Research Institute and learn some of the global public health interventions and national public health interventions that are made across some of those medical research institutes. TGA is another place where people go. So the role of public health in analysis of safety and quality for medical devices and medical interventions. So plenty of pathways, but oftentimes a bit of a clinical period, Masters of Public Health, and then we welcome people into the fold as public health registrars to do AFM training on the job.
Great. Do you think there's any particular sort of person or attributes that are best suited to a career in public health?
I'm not sure there are. You know, I think people settle naturally into whether they're largely, a people person, or largely want to be involved in a highly technical, not particularly person-facing environment. Public health is both. And you can find your space within that. So, you could have public health folk who never want to sit in front of another human being for the rest of their lives, who could work on policy and do it reasonably successfully. I do think there's a huge element in public health which relates to understanding communities and understanding needs and understanding health issues on the ground. And so that intersection with community engagement and liaison is a really core component for a lot of public health work. Equally said, there are some foundational elements that inform public health that can be pretty technical. That does relate to the work of the Australian Technical Advisory Group on immunisation. So an understanding of the epidemiology of disease transmission, what it means to have a vaccine of a particular kind. They are public health competencies, and so you could work in a pretty technical field and not so much a community facing or community focused field. I like the breadth of it, really. So I think you can pick your own space in public health in the way that people do across the breadth of medicine.
Probably a lot of people are interested. What's your work-life balance like, and perhaps what do you think it's like more broadly in your profession in public health?
Yeah, mine's pretty rubbish. I'll always be blunt talking about my own experiences. A pandemic is a challenge for the world. This is a 1 in 100 year pandemic, and so the days are incredibly long. It was a 7 days a week job for months and months. I've got Alan Cheng as the Deputy Chief Health Officer, who's been standing in for me on a once a week basis. It gives me that 1 day off a week, but all the other days of the week are full, and I've just got to cop it. Now that's not going to be the case for years to come. And outside of pandemics, it's a reasonable job when I compare it to being on call 1 in 3 as an emergency deputy director or acting director, and all the retrievals that were done in the middle of the night and the shift work, and the fact that there are shifts that start at 2 and finish at 10:30. Public health work is largely a 9 to 5 job. The misconception that public servants are going to the pub at 2 in the afternoon and then going home from there, it may have been true in the 80s. I wasn't around to know, but it is not true at all now. There are very many hardworking people. There are some people who do particularly long hours at particular times, but it's got the ebb and flow of work that you kind of expect across the public service and really across clinical work, good days and bad days in that regard. But it is a working hours job, and government's pretty good at supporting you for flexible work arrangements for some of the entitlements that public servants look to in joining the public service for long service leave and superannuation and all of that. So pretty bad now, but in normal circumstances, it's a nice balance, and I get to see my kids and get to have the flexibility to do school drop off or pick up or take some of those other opportunities, because it's a job that doesn't require you to be on site in an office 24/7. We've certainly learned that through COVID, with most of the COVID response working from home, and successfully so.
Great. It sounds like a Masters of Public Health was one thing that you recommend for people interested in pursuing a public health career. Is there any other sort of bits of advice that you think or particular things you think people should do?
It's not for everyone, but I think international work opens your mind up to some of the really core considerations in public health, and so you get to see outbreaks of vaccine preventable diseases that shouldn't occur. You get to see the effects of unclean water and poor conditions of sanitation, and how that manifests in a cholera outbreak, one of which I responded to in Kabul in 1997. Entirely preventable. It engenders that passion for public health, and I think if you haven't been exposed to some of those consequences of the poor social determinants of health, the social determinants of ill health, if you like, if you haven't been exposed to that, you won't feel that sense of connection and passion to public health endeavours necessarily. Certainly for that communicable disease side. On the environment side, the same applies. You see that play out in international humanitarian development work. And so if it's your thing, and if you've got the flexibility and a bit of sense of adventure, then a deployment with MSF or the Red Cross or WHO in a humanitarian response is a good thing. Australia does it as well. So I've done some deployments with AUSMAT, so the Australian Medical Assistance Team, under DFAT's auspices. So the National Critical Care and Trauma Response Centre in Darwin maintains a register of people who are willing to be deployed for responses. It has been kind of clinical disaster focused, but increasingly with the measles outbreak in the Pacific, and then with some of the challenges in PNG, has a broader and more public health focused element to some of those deployments. So putting your hand up to get on that register and going for a short period of time where you can get a break from clinical work is another opportunity, I think, for people. And then, as I say, remote and rural work in Australia brings some of those issues to the fore in terms of system strengthening and the social determinants. So whether it's an Aboriginal community or another remote community, I think it can be very useful as well.
I thought of one more question. Have you had particular mentors? Would you advise people to try and seek mentors in the area that they are thinking about?
Yeah, I've had mentors. I think it does depend whether you want to be in government, and then you should look to a deputy secretary or an executive director for both the machinations of government that can remain a bit of a mystery to a lot of people, remains a bit of a mystery to me to this day, but also the public health physicians and others who work in public health, not always public health physicians, who are senior epidemiologists, who are field epidemiologists, who might have worked for WHO or who are now in medical research institutes. So lots of great people across some of those MRIs that I mentioned before, who mentor people in public health training. So yeah, put your hand up and reach out is what I'd say.
All right, we'll jump into the third section. Hopefully we've got a couple of minutes at the end to answer a couple of questions that have come through. So the future of public health. How do you think COVID's changed the way we think about public health as a community, as government, and as medical practitioners?
Well, I make no assumptions, but my aspiration is that people clearly see public health as fundamental in protecting health and well-being, and indeed as a consequence, social capital, social structure, economic prosperity. How it plays out is anyone's guess. We don't have great long-term memories when it comes to some public health challenges. Certainly, the Spanish flu changed the way that we thought about public health in Australia and globally. The role of Chief Health Officer was invented in 1919 in Victoria and was written into the Act at that point in time. That was clearly in response to Spanish flu. I hope we get some fundamental changes in the way that we think about public health again, 100 years later, which is, for me, fundamentally that there is no downside to profound investment in public health. So whether or not you're just thinking about the 1 in 25 years or 1 in 10 years, as it might be into the future, pandemic events and what that investment means in terms of our readiness and our capability to respond, or the broader work of public health, the return on investment is really significant. And so it might be a gun amnesty, it might be a smoking cessation intervention, it might be something that relates to population level behaviour change to reduce the risk of cardiovascular outcomes. They are really, really powerful interventions. They don't have the sexiness of the individualised super technical intervention, but they make a huge difference. And so I think at a population level, that's dawning on us through the prism of COVID. But I hope that there's a view that even more broadly, there's enormous power in public health. And again, the Flint water crisis in the US, where lead contamination poisoned thousands of individuals and led to permanent brain damage for some children, that's the same thing. That's a question of making an investment in clean water so that we never have to deal with the consequences of what it would mean should it not be that way. And so I think that will be a shift in public health. I think people will see that resourcing to preparedness and response capability is something that is a no-brainer in terms of investment.
What do you think might be some big challenges in the next 10 to 20 years in the field of public health?
Look, I think antimicrobial resistance is absolutely one. We've seen carbapenemase producing Enterobacteriaceae, so CPE, as a top shelf multi-drug resistant organism that's going to cause outbreaks. It'll shut down wards, it'll shut down ICUs sometimes, but it's got a huge health cost for the individual. And the projections, if they're right, that suggest that AMR will kill more people than cancer by 2050. That's a trajectory that none of us want to go on. And so I think we need to be looking at that now. And again, the preparedness and the early interventions in that space will be something that will reap dividends, but it will be an ongoing challenge. You don't invent a new antibiotic overnight, and the way that bacteria work will just mean that it's a protein challenge as we go forward. Climate change, without question, is already impacting Australia, will continue to do so. And there are some really, there are going to be really negative consequences for health ahead of us, regardless of what we do in terms of carbon footprint from tomorrow. And so there's an adaptation piece of work that needs to be done, informed by public health, as well as a genuine mitigation effort and advocacy that needs to be done to make sure that the future of 2050 is better than it might otherwise be. And so, if I just reflect on air quality, we expect good air quality. We will have years of poorer air quality than we've had in the previous 20 years by virtue of significant bushfire risk in Victoria. And so that's going to be just one of the, multitudinous challenges in climate change. Our water catchments have burnt in previous years with bushfires. That's a challenge to our water supply and to our water quality. And then when you think about what it means for food poisoning with average increase in temperatures, the rise of water levels and what that means for our foreshores, and the broader challenge of biodiversity and how that intersects with a whole bunch of things, including the risk of pandemics. And so there's there is no end of work and challenge in public health in years coming forward. But I think there's some significant ones. It's pretty clear that we've still got challenges in terms of our increasingly sedentary behaviour, and what screen time will mean for a generation of children coming through who not only don't spend as much time exercising, but don't spend as much time in the outside world. And our deepening understanding of what that means for mental health and broader wellness, those are also clinical challenges, but they're absolutely in the public health space.
Yeah, that's so true. I hadn't thought of it that way. How do you think or hope that the specialisation of public health may develop over the coming decades to address those challenges?
I certainly hope it gets greater prominence in preclinical years. I hope that there are placements that can happen in government, in public health institutions for medical students coming through, so they get a better sense of as I say, the power and presence of public health, but also the specific efforts in workforce development are scaled up. There have been reports from the faculty of AFM, that essentially show that we've got 300 FTE equivalent of public health physicians in the country, many of whom are, old and crusty like me, and may not have 30 or 40 years of work ahead of them. And so we really need to make those investments now, and we need to have a clearer and better advertised and more embedded pathways for development of public health physicians, but also to think about the public health workforce in much broader terms. So yes, for medical graduates, but also mobilising the very best of all Masters of Public Health graduates, Doctor of Public Health graduates, and others who come through other pathways, including environmental health officers, not often thought about in the public health sphere, but they are the beating heart of food safety, noise complaints, a lot of things that happen in local council that are absolutely public health work. And so our investment in environmental health workforce as well needs to be ramped up and maintained, and we need to see that it's a genuine threat to our response capability if we haven't got those people that we can immediately mobilise, even if they're not working on it every single day.
How can the next generation of doctors help advance the field of public health?
Yeah, I think in getting this word out, so everything that I've spoken of this morning is understood at various levels across the health sector, in medicine more generally, and then across the community. So the advocacy for those population and prevention health elements in particular, and then on the magnificent work that's been done across Australia in public health, highlighted in the last year, that needs to be better understood, and we need to make sure that rather poor short-term memory for public health doesn't fade away. That the next challenge, and it might be another thunderstorm asthma event, it might be another Hazelwood coal mine fire. They are different challenges every year, but they come up with particular regularity, and they will do so increasingly. And so we need to work on that continuously.
Thanks, Brett. We've got one question from the chat group. We might just go through what we've got time for. We've only got a few minutes left, but I think this is a great question. What has helped you maintain sanity over the past year and a half, as well as to your previous experiences, such as working in Afghanistan?
Sure. So, look, there's a big assumption there that I've maintained sanity, but no, it's fair to say it's been enormously challenging. I've had my moments. The fundaments of maintaining your own well-being are the things that my wife reminded me of continuously through really the worst part of last year, which was try and get as much sleep as you possibly can, because the work will always be there and it will be piled up, and so you cannot go to midnight continuously and expect that you've got a capability to do that day in, day out. Eating properly, these are pithy responses, but they are really quite fundamental. we had Marley Spoon delivered again through wave 2. Cooking at home is really good for you. So, it's healthy food. It's an opportunity to involve your kids and whatever else. That was also part of my sanity. Getting exercise every day. Didn't do that very well, but I certainly did more running than I've done at other times. We live next to a national park, so every day was a half-hour walk if I possibly could, almost always with headphones on in a meeting, but nonetheless getting out there and getting outside, that's a really important thing. And then that compartmentalising some separation from work, even for a short period of time. So I try to do more meditation than I would routinely, and if I weren't meditating, it's just handing your phone over and walking away from it. So not thinking about work 24/7, because it's the ruminations on every decision that you make that really weighed on me more than anything. I'm not naturally anxious, and I didn't suffer from depression, but I did speak to a psychologist because of that rumination. And so that's the last thing I'd say. Reach out for assistance, informal, formal, professional, colleagues, family. If you've got times of struggle, there is no reason to treat mental health struggles or psychological struggles any differently than any other struggle. So, broken finger gets buddy strapped. A psychological challenge, there are many, many people around you who are ready to support you and who have the skills and competencies to help you through it. So for me, I got an opportunity to vent, and I got some of that kind of psychological hygiene advice around those fundamental things. And the main one that a psychologist told me was to push back on work, because work is doing what it needs to do. There was a huge crisis response going on. The demands on you as Chief Health Officer, because you can't hand it over for days on end to anyone else, are continuous. And so trying to create some barriers that allowed me to work effectively through that time were important. In Afghanistan, I was just...
Sorry to interrupt you. We're just going to run out of time, and I just wanted to say thanks very much for joining us.
Sure.
15, but this is amazing advice. Thank you so much.
No, thank you all, and thanks for everyone who's listening, all 52 of you.
Thanks. Have a good weekend.
My pleasure. Thanks all.